Ever get that nagging feeling that something you just take for granted could actually be, well, a hidden danger for your furry family member?
Mm-hmm.
Forget about, that time they chewed up your favorite shoe. We're talking about something quieter, a
Mhm.
silent threat maybe that could be going on inside them without you even realizing it.
Yeah, until it starts causing some real problems.
Exactly.
And today, we're taking a deep dive into something called copper-associated hepatopathy, or you'll hear it called QAH.
QAH.
Okay.
It's a really important condition, actually. It affects both dogs and cats. And getting a good understanding of it can truly help us keep them healthier.
Okay, copper-associated hepatopathy, QAH. It definitely sounds like a mouthful. So in simple terms, what's actually happening?
Well, at its heart, QAH is basically when an unhealthy amount of copper, just too much copper, builds up inside the liver.
Okay, too much.
Yeah. And this excess copper can then lead to inflammation. That's the hepatitis part, or scarring, which we call cirrhosis.
Right, Sirix. And in really serious situations, it can unfortunately lead to liver failure.
Wow, that's definitely concerning.
Yeah.
Can this copper buildup happen in, like, different ways?
Yes, yeah. There are basically two main ways it occurs. You've got primary QAH, where the copper accumulation is it's either due to the animal itself, like a predisposition,
Oh.
or it's the main driver of the liver issues.
Mhm.
And then there's secondary QAH.
And secondary means.
That's where the copper builds up more because of some other underlying liver problem that's already happening.
Got it. So our mission for this deep dive then is to really get a handle on QAH. We want to understand, what causes it, how we might recognize it,
Hmm.
and most importantly, what can actually be done to help our pets. It sounds like we've got some pretty in-depth information to guide us through this.
We do, yeah. Our sources cover, the definition of QH, the different things that can cause it, how it's diagnosed, and importantly, the ways we can manage and treat it. It's a pretty comprehensive look at a really vital topic for any pet owner, really.
Okay, great. Let's start with the basics then. We know copper is, well, it's an element, it's out there. What's its normal job in a dog or cat's body? I mean, presumably we need some.
Oh, absolutely. Copper is actually an essential mineral, even though, we only need it in pretty tiny amounts.
Right. Trace mineral.
Exactly. It plays a crucial role in all sorts of bodily processes. And the fact that our sources talk about the body trying to maintain a neutral copper balance really highlights that, yeah, we need some, but too much is definitely the problem here.
And how does the liver, which is, such a workhorse organ, how does it normally manage copper levels?
The liver has this very sophisticated system, actually, for dealing with copper. It gets absorbed in the small intestine, then it travels to the liver where some of it's stored.
Okay.
Normally, any extra copper, anything the body doesn't need right then, is removed from the liver and it goes into the bile.
Ah, okay. Excretion through bile.
Precisely. And the bile then leaves the body. This whole process is really tightly controlled by, well, a number of different players, different proteins and
Yeah,
things.
who are the key workers in this copper management team in the liver?
Well, you can think of it like a really well-organized transport and storage system inside the cells. You've got protein transporters that physically move the copper around.
Mm-hmm.
Then there are chaperones that kind of guide it to the right places within the liver cells.
Okay.
You've got membrane receptors controlling what comes in and out, intracellular binding proteins that store it safely.
Right.
And finally, these things called canalicular egress pumps that actively push the excess copper out into the tiny bile ducts.
Wow.
It's a really intricate balancing act,
It
honestly.
sounds incredibly complex. Okay, so that's how it's supposed to work. What happens when that system breaks down and we get this primary QAH? We heard about genetic, acquired, and congenital forms. Let's maybe tackle the genetic side first.
Okay. So the only cause of primary QAH that we've definitively linked to one specific gene is a mutation in something called the COMMD1 gene.
COMMD1.
Yeah, COMMD1. This was found in Bedlington Terriers, and essentially this genetic glitch means their liver cells just can't get rid of copper properly. It builds up.
And it's almost hard to believe that at one point such a huge number of Bedlington Terriers actually carried this mutation.
It was a massive health concern for the breed, absolutely. Our information indicates that, yeah, at one time, maybe up to 2/3, 60–70% of Bedlingtons carried this COMMD1 mutation.
Wow.
The good news, though, is that genetic testing became available.
Right. That's key.
Huge. It allowed breeders to make much more informed choices screening their dogs, and that's really significantly reduced how often we see it now.
That's great progress.
It is. But it's interesting because our sources also mention that some Bedlington Terrier families, kindreds who definitely have QAH, they've actually tested negative for this specific mutation.
Oh, really? So it's not the whole story, even in Bellingtons?
It suggests that, yeah, there might be other genetic factors involved that we just haven't identified yet. So I think the key insight there is, the power of genetic testing is huge, but also our understanding is still evolving. There might be more to it.
Okay, so genes play a role, potentially multiple genes sometimes. What about this acquired primary QAH? That sounds like something that develops over their lifetime, not something they're necessarily born with.
Exactly. And this is actually the most common reason we see primary QAH in dogs these days.
Oh, the most common.
Yes. The current thinking, based on the evidence, is that it happens when the amount of copper in their regular commercial dog food is just more than what that particular dog system can handle to maintain that healthy copper balance we talked about earlier.
So hang on. It's not necessarily that the food is like wildly overloaded with copper for every single dog, but maybe that some individual dogs are just more sensitive to the levels that are typically present.
That's precisely it. The information really points towards likely individual differences in how those copper transporters and other parts of the system actually work.
Right.
And these differences might even be connected, maybe unintentionally, to genetic shifts that have happened as we've selectively bred dogs for certain breed characteristics over time.
Ah, interesting. Like an unforeseen consequence of breeding.
Possibly, yeah.
Yeah.
So another really important point is that these individual sensitivities seem to play a big role. What's fine for one dog might be too much for another.
And what about our feline friends? The sources mentioned a congenital primary QAH in cats. Does that mean they're born with it?
Yes, congenital implies it's present from birth. This does occur in cats, but it's considered relatively rare compared to what we see in dogs.
Okay.
And interestingly, unlike the Bedlington story, we haven't yet pinpointed a specific single gene mutation in cats that causes this condition.
Okay, now here's where it gets really interesting for me. The information we have says that some animals with primary QAH can have this significant buildup of copper without actually showing clear damage to their liver tissue when you look under a microscope, even though their liver enzyme levels, like ALT, might be bouncing around.
Right. ALT, alanine aminotransferase, it's a common liver enzyme we check.
Exactly. So high copper, maybe high enzymes sometimes, but the liver tissue looks okay initially. That's quite surprising.
It really highlights how complex this whole thing is. We don't fully understand why some animals seem to tolerate higher copper levels, at least for a while, without obvious microscopic damage, while others develop significant problems much more quickly.
Yeah.
It suggests the body might have some, initial protective mechanisms or maybe different thresholds for damage.
And where in the liver does this copper typically start to accumulate in these primary QAH cases? Is there a specific spot?
Yes, there is. In primary QAH, the copper initially accumulates predominantly in what's called zone 3 of the liver lobule.
Zone 3.
Yeah, think of the liver being made up of these tiny functional units called lobules. Zone 3 is the area right around the central vein within that unit, the central lobular region.
Okay, central lobular, zone 3. And just to give us a sense of scale, how much copper are we actually talking about in these primary cases? What are the levels like?
The amount of copper measured in the liver tissue and primary QAH can vary, well, quite a bit actually. It ranges typically from around 500 micrograms per gram of dry weight liver tissue,
Okay, 500.
all the way up sometimes to over 10,000 micrograms per gram.
10,000. Wow, that's a huge range and potentially a massive accumulation compared to normal.
It really is. The level of buildup can be incredibly substantial in these primary cases.
Okay, that's a huge range, as you said. Now, let's maybe switch gears and talk about the secondary copper-associated hepatopathy. What's the main driver behind that type?
So in cats, secondary QAH is mainly caused by the liver just not being able to excrete copper into the bile properly.
Right, that excretion pathway we mentioned.
Exactly. And this failure to excrete is usually due to severe long-term cholestasis.
Cholestasis.
Yeah.
That's where bile flow is blocked or slowed down.
Precisely. So if bile isn't flowing out properly for some other reason, copper backs up. Interestingly, the information we have specifically notes that this type of secondary QAH linked to cholestasis isn't typically seen in dogs.
Oh, okay. So it's mainly a cat thing with the cholestasis link.
Primarily, yes.
So what about dogs then? What can lead to secondary copper buildup in them, if not usually cholestasis?
In dogs, secondary QAH is quite rare, actually, and when it does happen, it's mostly linked to something called fulminant hepatic failure.
Fulminant, meaning sudden and severe.
Exactly. A very sudden, catastrophic kind of liver failure. This widespread, acute liver damage seems to disrupt all the normal processes, including the ones the liver uses to handle copper, leading to some secondary accumulation.
Gotcha. And does the location where the copper builds up differ in secondary QAH compared to that zone 3 pattern in primary?
Yes, it often does, particularly in cats with secondary QAH due to cholestasis. The copper tends to accumulate more in zone 1 of the liver lobule.
Zone 1, so a different area.
Yeah, remember zone 3 was around the central vein. Zone 1 is out near the edges, around the portal triads. It's a different neighborhood within the liver unit.
Okay.
And it can also sometimes accumulate just adjacent to areas where there's already other liver injury happening.
And are the copper levels typically as extreme in these secondary cases compared to primary?
Generally, no. The sources indicate that in secondary QAH, the copper levels measured in the liver rarely go above about 1,000 micrograms per gram of dry weight liver.
Okay, so still higher than normal, but maybe not reaching those really, really high levels we see in some primary cases.
Exactly. So while it's still an abnormal accumulation, it's usually not quite as profoundly elevated as what we often see in primary QAH. And this difference in both location zone 1 versus zone 3 and the level of accumulation can actually be important clues for figuring out what's going on during diagnosis.
That makes sense.
Okay.
Okay, so we've established the copper is building up either primarily or secondarily. But how exactly does this extra copper actually cause damage to the liver? What's the mechanism of harm?
Well, the main way excess copper seems to damage the liver cells, the hepatocytes, is through something called oxidative stress.
Oxidative stress, okay? Like free radicals.
Precisely. The extra copper acts as a catalyst, basically encouraging the formation of these nasty reactive oxygen species, or free radicals. These then attack and damage crucial parts of the cell, especially the cell membranes and the mitochondria.
Ah, the mitochondria, the cell's energy factories.
Exactly. So think of it as the copper causing this kind of internal corrosive damage, almost like rusting from the inside out at a cellular level.
So it's like the copper itself is creating this toxic internal environment, causing wear and tear on the liver cells.
That's a really good way to put it, yeah. And this initial oxidative damage can then trigger inflammation in localized areas. That's focal hepatitis.
Okay.
Over time, if the copper overload continues, this inflammation can become more widespread and persistent, leading to chronic hepatitis.
Which is ongoing inflammation.
Right. And eventually, that chronic inflammation leads to the formation of scar tissue replacing healthy liver tissue, and that's cirrhosis.
Right, and the liver loses function as it gets scarred.
Exactly. The information also suggests that this long-term inflammation might, in some cases, even trigger the body's own immune system to start attacking the liver, adding another layer of damage.
Wow. And I recall reading about a really severe, though apparently uncommon, consequence involving a sudden release of copper. Could you explain that a bit more?
Yeah, that's a scary scenario, thankfully rare. It usually happens when there's sudden and very severe liver cell death, maybe in that fulminant failure context we mentioned.
Right.
The damaged, dying liver cells basically rupture and release large amounts of stored copper into the bloodstream all at once.
Oh, wow, a sudden flood of copper.
Exactly. And this sudden surge of free copper circulating in the blood can be incredibly toxic systemically. It can lead to hemolysis.
Destruction of red blood cells.
Yes, causing severe anemia quite rapidly. And it can also, again, rarely trigger something called acute onset acquired Fanconi syndrome.
Fanconi syndrome. It affects the kidneys.
It does. It's a specific type of kidney damage where the proximal tubules in the kidneys stop functioning properly. They can't reabsorb things like glucose, amino acids, bicarbonate like they should.
So you might see glucose in the urine even if blood sugar is normal.
Exactly. That's a classic sign, euglycemic glucosuria. So in these really severe acute situations, the damaging effects of copper overload can unfortunately extend beyond just the liver itself.
So it's clearly not just the liver that can suffer in those extreme, thankfully rare situations. Now, we've talked quite a bit about Bedlington Terriers, obviously. Are there other breeds we should be particularly aware of when it comes to a higher risk of QA?
Yes, absolutely. While that COMMD1 link is strongest in Bedlingtons, several other breeds definitely have a known higher risk, a predisposition to developing primary QH.
Okay, like who?
Well, our sources consistently list Labrador Retrievers.
Labs. Wow, they're so common.
Very common, yes. Also, West Highland White Terriers, Doberman Pinschers, Dalmatians, Welsh Corgis, Keeshonds, and Staffordshire Terriers.
That's quite a diverse list.
It is. But it's really important to stress, as the sources do, that no breed of dog is completely immune. We can see QAH in pretty much any breed, and mixed breeds too.
Okay, that's a crucial point.
Yeah, so the key takeaway here is while some breeds clearly have a higher genetic risk, all dog owners should probably be aware of this condition as a possibility.
And there's also a mention of Skye Terriers having had issues historically as well.
That's right, yeah. There are historical records and reports indicating a higher occurrence of QAH or conditions very much like it in Skye Terriers in the past.
That really is quite a list of breeds. It's also, frankly, surprising to learn from the sources that QAH has apparently become the most common cause of long-term elevated ALT levels, that liver enzyme we keep mentioning in dogs since around the mid-1990s. That seems like a really significant shift.
It is a significant observation, yeah. And the information strongly suggests this increase might be related to changes in how copper supplements, particularly highly available forms of copper, were added to commercial dog foods around that time.
Ah, so a potential dietary link to the increase.
It's a strong hypothesis. It really highlights how even seemingly small changes in widespread dietary formulations might have unintended, important health consequences for some susceptible individuals in the population.
Yeah.
And it's also worth repeating that point we touched on earlier. Just because a dog has a high level of copper measured in their liver, say above that 400 micrograms per gram dry weight benchmark, it doesn't automatically mean there's visible microscopic damage happening to the liver tissue, at least not yet.
Right. The copper can be there before the damage becomes obvious.
Yeah.
That leads us perfectly into how we actually recognize the signs. If copper can build up silently, what are the things pet owners should be watching for? What does this look like?
Well, the way primary QAH presents can be incredibly varied. Some animals honestly might not show any outward clinical signs at all, especially early on.
Completely asymptomatic.
Yes. Or they might have what we call subclinical disease, where the only hint is maybe those elevated liver enzymes found on routine blood work.
Okay.
Then, in less frequent cases, you can have that sudden, acute onset of severe liver damage we talked about, the fulminant type.
Right. The really dramatic presentation.
Yeah. And then there's perhaps the more common scenario, which is a chronic progressive hepatitis. This often affects middle-aged to older dogs, and it sort of smolders along, gradually causing damage that can eventually lead to cirrhosis.
And what about secondary QA? Do the signs differ?
Well, with secondary QAH, the signs are often kind of mixed in with or dominated by the signs of the underlying condition. So in cats, that might be the signs related to their chronic cholestatic liver disease, like cholangiohepatitis.
Okay.
And in those rare dog cases with secondary buildup due to fulminant failure, well, the signs are those of severe acute liver failure itself.
Okay. What about the more immediate, sort of acute signs that might make a pet owner think, okay, something is seriously wrong, I need to get to the vet right now?
Yeah, good question. Acute signs to watch for would include a sudden onset of profound tiredness or lack of energy, real lethargy, also a sudden loss of appetite, going off food completely, which we call anorexia, and vomiting. Sometimes the disease can progress alarmingly quickly in these acute cases. And sadly, as the sources mentioned, some animals may not survive even with intensive veterinary care if it hits them that hard and fast.
That's sobering. And what about the more gradual chronic signs that might develop over weeks or months, the ones that might be easier to miss initially?
Right, the chronic signs can be quite sneaky because they're often variable. They might even seem to come and go a bit.
It's intermittent.
Exactly. These can include things like just ongoing tiredness, maybe not full lethargy, but just less energy than usual, reduced appetite, what we call hyperexia rather than complete anorexia.
Yeah.
Gradual weight loss, maybe some intermittent vomiting or diarrhea, and sometimes increased thirst and urination, polydipsia, and polyuria, or PDPU.
Right, drinking and peeing more.
Yeah. Then, as the liver disease gets progressively worse and liver function really starts to decline, you might see more obvious, serious signs. Things like a swollen, fluid-filled abdomen due to ascites, jaundice, that yellowing of the skin, gums, and whites of the eyes. Maybe increased bleeding tendencies like bruising easily or blood in the stool, and eventually signs of hepatic encephalopathy, or HE.
Which is the neurological signs.
Yes, neurological problems like disorientation, pacing, head pressing, even seizures, because the failing liver isn't filtering toxins like ammonia from the blood properly, and they affect the brain. So if you see these kinds of progressive signs building up, it's definitely time for a vet visit.
Absolutely. Are there specific things a veterinarian might pick up during a physical examination that could point towards QAH?
Yeah, the physical exam findings often mirror those signs. In acute cases, a vet might observe profound lethargy, weakness, maybe that jaundice is visible, or pale gums if there's anemia from hemolysis.
Okay.
They might note vomiting or diarrhea during the exam and see that the urine is very dark, usually due to bilirubin, but rarely it could be hemoglobin if hemolysis is severe.
And in the more chronic cases?
In chronic cases, they might find evidence of weight loss or poor body condition, feel that fluid wave if there's ascites, see jaundice again. Sometimes they can feel the liver itself, and it might feel smaller than normal and maybe have a bumpy or nodular texture that's microhocacia.
Ah, the cirrhotic changes.
Exactly. And in really severe end-stage cases with poor clotting, they might also see evidence of bleeding, like melena, that dark tarry stool from digested blood, or tiny pinpoint hemorrhages called petechiae on the skin or gums.
Okay, so the signs can be really diverse, sometimes quite subtle early on, which really emphasizes the need for good diagnostic testing. How do veterinarians actually pin down this diagnosis of copper overload? What tests are involved?
Well, routine blood work is usually the starting point. That typically includes a complete blood count, or CBC, a serum biochemistry profile, and a urinalysis.
Standard stuff.
Pretty standard initial workup, yeah. Now, in the very early stages of QH, these tests might actually come back completely normal.
Really? Even with copper building up?
It's possible, yeah. Or they might just show non-specific increases in those liver enzymes we've been talking about. ALT, AST, maybe GGT, and alkaline phosphatase, or ALP.
Okay.
And remember, the information suggests that often the ALT level goes up more significantly or maybe earlier than the ALP level does in QH.
And that isolated rise in ALT may be found incidentally on wellness blood work without any obvious symptoms that could be an early warning sign.
Exactly. An unexplained, persistent increase in ALT, even in a dog that seems perfectly healthy, should definitely raise suspicion for possible early or maybe cyclic intermittent liver cell damage, potentially associated with QEH, especially in a predisposed breed. Then, as the liver's ability to function really starts to decline, you might see other changes on the biochemistry profile. Things like low protein levels, specifically low albumin or hypoalbuminemia, possibly elevated globulin levels, hyperglobulinemia, low blood urea and nitrogen, or BUN, because the liver makes urea, rarely low blood sugar, hypoglycemia, especially in small dogs, or severe failure, and sometimes low cholesterol levels, hypocholesterolemia.
So a range of biochemical clues can emerge later on.
Yes, reflecting that declining liver function. But it's also really important to know, as the sources emphasize, that measuring the level of copper in the blood itself, serum copper, is not a reliable way to screen for or diagnose QAH.
Yeah, that's crucial, so a blood copper level isn't helpful.
Generally not. It doesn't correlate well with the amount of copper stored in the liver, which is what really matters.
Okay, so blood tests can give us hints, especially the liver enzymes, but they don't give us a definitive diagnosis of copper overload itself. What's the next step then? How do we confirm it?
Right. The sources are very clear on this. To truly diagnose QAH and understand its significance, we absolutely need to combine measuring the amount of copper within the liver tissue with a histopathological examination.
Histopathology, that's looking at the tissue sample under the microscope.
Exactly. Looking at the liver architecture, the cells, the inflammation, the scarring, and importantly, where the copper is located in relation to any damage.
Okay.
Now, for Bedlington Terriers, as we mentioned, genetic testing can be very helpful to specifically look for that COMMD1 mutation or related markers.
Right.
Imaging, like X-rays and especially ultrasound, might also be part of the workup. Although, again, in the early stages, the liver might look completely normal on ultrasound.
Okay.
Later on, as the disease progresses, ultrasound might start to show changes in the liver's texture. Maybe it looks brighter than normal, hyperchoic, or has a mixed brightness with regenerative nodules forming. And of course, ultrasound is great for detecting fluid in the abdomen if ascites has developed.
But it sounds like getting that actual sample of liver tissue, the biopsy, is really the cornerstone for a definitive diagnosis.
Absolutely essential. A liver biopsy serves multiple crucial purposes. It confirms the diagnosis, it allows us to assess the severity and type of liver injury, and it provides the tissue needed for quantifying the copper.
And how do they see the copper in the biopsy slide?
Well, standard stains used in pathology, like H&E, might not always make the copper itself clearly visible, especially at lower concentrations. So it's vital to request special copper-specific stains.
Ah, special stains.
Yes. Rhodonine is generally considered the preferred one, but rubianic acid can also be used. These stains bind to the copper, making it visible as distinct granules, often reddish-brown with rhodonine.
Okay.
This allows the pathologist to see the copper protein clumps, confirm where they are located within the liver lobule, like in those zone 3 hepatocytes we discussed for primary QAH, and assess how the copper distribution relates to any inflammation or cell death.
And they can estimate how much copper there is just by looking.
They can get a rough idea, yes. There are semi-quantitative scoring systems pathologists use, grading the amount of stained copper granules from 0 to 5, for instance. But this is still an estimation.
So how do they get the precise measurement, the actual number, like those micrograms per gram you mentioned?
For that precise quantification, the gold standard method is a technique called atomic absorption spectroscopy, or AS.
Okay, atomic absorption. Sounds fancy.
It's a specialized lab technique. It requires a decent amount of liver tissue, ideally from a full needle biopsy core or a wedge biopsy, not just tiny fragments. And crucially, the results must be reported per gram of dry weight liver tissue.
Why dry weight?
Because the water content of a liver sample can vary quite a bit depending on how it was handled, if there's edema, etc. Drying the sample first removes that variability, giving a much more accurate and comparable copper concentration. Methods that estimate hydration or report copper on a wet weight basis are less reliable and should be interpreted with caution.
Good to know. Dry weight is key for accuracy. Are there other ways to quantify it now?
Yes, the sources also mentioned that using digital image analysis to scan those rhodonine-stained biopsy slides is becoming a validated alternative method.
Oh, using computers to analyze the stain.
Exactly. Software can precisely measure the area and intensity of the rhodonine stain, and this has been shown to correlate very well with the copper levels measured by AS. A bonus is it directly links the measured copper amount with what the pathologist is seeing under the microscope regarding location and damage.
That sounds like a great advancement. Now, remind us again, what are the normal copper levels in the liver compared to what's considered elevated or diagnostic for KAH?
Sure. Normal hepatic copper concentration in dogs and cats is generally considered to be less than or equal to 400 micrograms per gram, dry weight liver, AGDWL.
Okay, under 400 is normal.
Right. In dogs with primary QAH, the levels are typically significantly higher than this.
Yeah.
We mentioned the Bedlington range earlier, maybe 850 up to over 12,000 dog games.
Mm.
Other predisposed breeds often fall into ranges like, say, 500 to maybe 2,500 nangs for Westies, Labs, Dobermans, Dalmatians, though they can certainly go higher too.
Okay.
And cats with primary QH can also have very high levels, maybe 700 up to 8,000 nangs. Again, these are general ranges, but clearly well above that 400 normal threshold.
Definitely. And just to reiterate, where exactly inside the liver cells does this copper tend to accumulate, especially in dogs with primary QH?
In dogs, the copper primarily builds up within tiny membrane-bound sacs inside the hepatocytes called lysosomes.
Lysosome. Okay.
And this accumulation happens preferentially in those hepatocytes located in zone 3, that central lobular region we talked about near the central vein. The special stains really help confirm the specific subcellular and zonal location and show how the copper granules are often associated with areas of cell injury or death.
And sometimes they form clumps.
Yes, the information mentions that sometimes, particularly in areas where liver cells have died off, aggregates of copper-laden macrophages and inflammatory cells can form, creating structures referred to as copper granulomas.
Okay, fascinating detail. So we've identified the problem, way too much copper, accumulating in the wrong place, causing oxidative stress and liver damage. What can we actually do about it? How do we treat and manage QAH once it's diagnosed?
Right, the treatment plan. For most dogs, thankfully, treatment can usually be managed on an outpatient basis at home.
Okay.
However, if an animal is showing significant signs of liver failure, like severe jaundice, ascites, or those neurological signs of HE, they will likely need to be hospitalized initially for more intensive supportive care to stabilize them.
Makes sense. What's the cornerstone of long-term management?
The absolute foundation, the most critical part of long-term management for all affected animals, is switching them to a lifelong diet that is restricted in copper.
A low-copper diet.
Yeah.
For life.
For life. There are several prescription veterinary therapeutic diets specifically formulated for liver disease that have low copper content. These are often referred to as liver diets.
Okay.
These diets also usually have a moderate amount of high-quality, highly digestible protein, which is important for liver regeneration, but not excessively high.
Is there ever a time when you need to restrict the protein in their diet even further?
Yes, sometimes. Protein restriction might become necessary in dogs that are showing clear signs of hepatic encephalopathy,
Right.
the brain signs, or if they start developing ammonium biurate crystals in their urine. Both of those suggest the liver isn't adequately processing the ammonia produced from protein digestion.
Oh,
In those specific cases, the protein level in the prescription liver diet might need to be reduced further. Sometimes a veterinary clinical nutritionist might recommend supplementing with specific low-copper alternative protein sources like cottage cheese or egg whites, but that needs careful guidance.
can owners make a low-copper diet at home?
It's possible, but it's generally quite challenging to do correctly. It needs to be very carefully formulated by a board-certified veterinary clinical nutritionist to ensure it's nutritionally complete and balanced, truly low in copper, and meets all the dog's other needs.
Sounds complicated.
It really is, especially for larger dogs where the volume of food is significant. Honestly, the prescription liver diets are usually the most reliable and convenient way to ensure consistently low copper intake. They generally have the lowest copper content available, typically around 4 milligrams per kilogram of food on a dry matter basis.
Okay.
They were actually originally designed, in part, to help manage copper levels in Bedlington Terriers. And many owners do report that their pets seem to have more energy and a better appetite once they transition onto these diets. Though strict adherence, no cheating with high copper treats is absolutely key for success.
Diet is clearly critical. But what about medications? Are there drugs that can actively help get rid of the copper that's already built up in the liver?
Yes, absolutely. That's where chelation therapy comes in.
Chelation. Sounds like grabbing.
It basically means to bind or grab onto. There are medications called copper chelators, like D-penicillamine and trientine, also known as triethylentretramine.
Okay, D-penicillamine and trientine.
Right. These drugs circulate in the bloodstream, bind to excess copper in the body, including helping to mobilize it from the liver, and form a compound that can then be excreted primarily through the urine.
So they actively pull copper out?
Essentially, yes. D-penicillamine is often the first choice, typically given at a dose of around 10 to 15 milligrams per kilogram of body weight twice a day. It's just given on an empty stomach, usually about an hour before feeding, to maximize absorption and effectiveness.
Okay.
Trientine is another option that works similarly. Chelation therapy is usually started in dogs who have confirmed copper accumulation on biopsy, especially if they also have elevated liver enzymes like ALT, indicating ongoing damage.
And how long do they need to be on these chelators?
It really depends on the initial amount of copper in the liver and how the dog responds. Some dogs with moderately high levels might only need treatment for, say, 6 months. Others with extremely high copper levels might need to stay on chelation for a year or even longer.
How do you know when to stop?
Monitoring is key. We regularly check their liver enzymes, particularly ALT, hoping to see it decrease towards the normal range. Ideally, though, the best way to know if the copper level has come down sufficiently is to repeat the liver biopsy after a period of treatment, maybe 6 to 12 months later.
Ah, another biopsy potentially.
It's the most definitive way to assess response. Are there side effects to watch for with chelators?
Yes, D-penicillamine can sometimes cause gastrointestinal upset, like vomiting or reduced appetite, especially when first started. Sometimes giving it with a small amount of food or using anti-nausea medication can help. Occasionally, a very low dose of prednisone might be used temporarily to manage side effects, but that needs careful consideration. Trientine is generally thought to have fewer GI side effects, but it's significantly more expensive. Right, cost can be a factor.
Definitely. And there have been rare reports linking very high doses of trientine to potential kidney issues, so appropriate dosing is important.
Okay. What about using zinc? I saw that mentioned as a potential therapy as well. How does that fit in?
Zinc therapy can be a useful tool, particularly for chronic long-term management or maybe in milder cases. It works quite differently from chelators.
How so?
Zinc primarily works in the intestines. When given orally, it stimulates the cells lining the gut to produce a protein called metallothionein. This protein has a high affinity for copper, so it binds dietary copper within the intestinal cells, preventing it from being absorbed into the bloodstream.
Ah, so it blocks copper absorption rather than removing what's already there.
Exactly. It helps maintain that neutral copper balance going forward by reducing intake. The typical forms used are zinc acetate or zinc gluconate, given usually an hour before meals to avoid binding with food components. Zinc acetate is often considered the best tolerated.
Is zinc as effective as chelation?
Studies, particularly human ones extrapolated to dogs, suggest zinc might not be as potent or as rapid as chelation therapy for actively reducing very high existing liver copper stores.
Okay.
So zinc might be more suitable for dogs in the earlier stages of QAH, perhaps those detected with elevated copper but minimal liver inflammation, or maybe those with lower levels of copper, generally below that 1,000 Tagline threshold. It can also be used for long-term maintenance after initial chelation has lowered the copper levels.
So maybe not the first choice for severe cases.
Probably not as the sole therapy if there's significant hepatitis and very high copper levels.
Hmm.
In those cases, chelation is usually preferred, at least initially, to get the copper down more effectively.
Can you use both together, zinc and a chelator?
You can, but they need to be administered at different times because zinc can bind the chelator and the chelator can bind zinc. Giving them together would reduce the effectiveness of both, so you typically need to separate the doses by several hours.
Makes sense. Any side effects with zinc?
The most common side effect is vomiting or sometimes gastritis, stomach irritation. Giving it with a small amount of food might help, although ideally it's given on an empty stomach. Monitoring serum zinc levels is also sometimes recommended during therapy to ensure adequate levels without causing toxicity.
Okay. Are there any other supportive medications or supplements that are often used alongside diet and maybe chelation or zinc?
Yes, definitely. Given that oxidative stress is a key part of the damage mechanism.
Right, the free radicals.
Exactly. Antioxidants are often recommended. Vitamin E is a common one. Same, S-adenosylmethionine is another supplement frequently used for liver support, as it can boost glutathione levels, which is a major intracellular antioxidant in the liver.
Okay, vitamin E and same.
Hepatoprotectants, drugs thought to help protect liver cells, might also be considered. Silibinin, the active component of milk thistle extract, has antioxidant and anti-inflammatory properties. Ursodeoxycholic acid, or UDCA, is a bile acid that can help improve bile flow and may also have protective effects, though its specific role in primary QAH is maybe less defined than in cholestatic diseases.
So several supportive options. Now, critically, are there any medications or supplements that should definitely be avoided in pets being treated for QAH, things that could make it worse?
Yes, this is really important. The sources specifically warn against giving supplemental ascorbic acid, which is vitamin C.
No vitamin C, why not?
There's evidence suggesting that vitamin C in the presence of high copper levels might actually worsen the oxidative damage it can participate in redox cycling that generates more free radicals in this specific context. So definitely avoid extra vitamin C.
Wow, okay, good to know. Anything else?
Also, non-steroidal anti-inflammatory drugs, NSAIDs like carprofen, meloxicam, etc., should generally be used with extreme caution or avoided altogether if possible.
Why NSAIDs?
Because some NSAIDs can potentially cause liver injury themselves, sometimes affecting that same centralobular zone 3 region where the copper tends to accumulate and cause damage in primary QAH. So there's a risk of additive liver injury. If pain relief is absolutely needed, other classes of drugs might be safer choices.
Okay, so avoid vitamin C supplements
Mm.
and be very careful with NSAIDs. That's crucial advice. So it sounds like the treatment involves a multi-pronged approach. The essential low-copper diet, potentially medications like chelators or zinc to manage copper levels, antioxidants, and maybe other liver support, and avoiding things that could make it worse.
That sums it up well, yes. It requires a dedicated long-term plan tailored to the individual animal's situation.
What about preventing QAH from developing in the first place? Is there anything owners or breeders can do?
Prevention is definitely key, especially in those breeds we know are more susceptible. For Bedlington Terriers, the strategy is quite clear: genetic testing.
Right, for the COM-MD1 mutation.
Exactly. Responsible breeders should be testing their breeding stock and making informed decisions to avoid producing affected puppies. There's even, as the sources mention, a liver registry maintained by the Bedlington Terrier Club of America for dogs that have been confirmed through biopsy and genetic testing to be free of the mutation and disease.
That's fantastic. What about the other breeds at higher risk, like Labs or Westies, where there isn't one single gene test yet?
For those breeds, it's more about awareness and early detection. Owners and vets should perhaps be more vigilant about monitoring liver enzymes like ALT, maybe as part of routine wellness checks, especially in middle-aged dogs.
So pick it up early if the enzymes start to rise.
Yes. And if a dog from one of these predisposed breeds needs a liver biopsy for any reason, it's definitely wise to specifically request those copper-specific stains, like rhodonine, and ideally quantitative copper analysis, even if QAH wasn't the primary suspicion initially. It helps build our knowledge base and might catch cases earlier.
That makes a lot of sense. Finally, what can owners generally expect in terms of the long-term outlook, the prognosis, once a dog or cat has been diagnosed with QAH?
The prognosis is, well, quite variable. It really depends heavily on the stage of the disease and the severity of liver damage at the time of diagnosis.
Okay.
It's generally considered poor, unfortunately, for those young dogs presenting with acute fulminant hepatic failure, or for older dogs that already have advanced cirrhosis with complications like ascites or HE when they're first diagnosed.
Tough.
It is, although it's worth noting that even some of these severely affected animals can sometimes respond, at least partially, to intensive treatment and management.
So there's still hope sometimes.
There can be, yes. For dogs diagnosed with milder, more recent liver injury, perhaps just moderate enzyme elevations and inflammation seen on biopsy without significant fibrosis yet, the prognosis is usually much better, especially with prompt initiation of chelation therapy and dietary management. And interestingly, the sources highlight that even some animals with quite advanced liver changes visible on ultrasound, like a nodular liver or even those of ascites, can sometimes show remarkable clinical improvement and have a good quality of life for a considerable time with consistent treatment. The liver has a surprising capacity for regeneration if the underlying insult is controlled.
That's encouraging.
Ultimately, the best prognosis is undoubtedly associated with early detection and treatment, ideally, finding and addressing the copper overload before significant, irreversible liver remodeling like fibrosis or cirrhosis has developed, and before severe clinical signs of liver failure appear.
So the main takeaway message here seems to be that copper-associated hepatopathy is definitely a serious condition, no doubt about it, but it's often something that can be managed effectively, especially if it's discovered early on and treated appropriately with the right combination of diet and medication.
That's absolutely right. Awareness is key. Knowing the risks, particularly if you own a breed that's known to be more susceptible, is so important. Recognizing those potential signs, even the subtle chronic ones, and then utilizing the diagnostic tools your veterinarian has available, especially liver biopsies with appropriate copper analysis, are all absolutely critical steps for successfully managing this condition and giving these pets the best possible outcome.
This has been a really, really insightful deep dive into QAH. It's complex, but understanding the pieces makes a huge difference. And it really makes you wonder, doesn't it? Given that potential link we discussed between copper levels in commercial pet foods over time and how different breeds seem to process copper differently, possibly due to selective breeding, what other subtle environmental factors, or maybe even more nuanced genetic predispositions that we don't even know about yet, might be quietly influencing the health of our animal companions?
That's a fascinating and important question. There's still so much to learn about gene-diet-environment interactions in our pets.
Absolutely. It's definitely something worth thinking about, maybe discussing with your own veterinarian, and certainly staying informed about as research in veterinary medicine continues to uncover more answers.